So our next speaker we have is Dr. Driss Ait Ouakrim, and he's a Senior Research Fellow and Epidemiologist in the SHINE unit, which stands for Scalable Health Intervention Evaluations. And that's led by Professor Tony Blakely at the Melbourne School of Population and Global Health at the University of Melbourne. Dr. Ait Ouakrim is an affiliate researcher with the Tobacco Endgame CRE and also the Healthy Housing CRE. And his research is focused on population intervention modelling and the health economic evaluation of public health policies. So now I will hand over to Dr. Ait Ouakrim.
Thanks, Coral. Good afternoon, everyone. I'd like to apologise to several colleagues who've seen this presentation several times. But I'm presenting two papers. One of them has been published. There's several co-authors, and then the second one is under review at the moment. I was going to give a bit of context, but that was covered by Richard this morning. So we did this modelling in the context of the Smoke-Free Action Plan in New Zealand. We were approached by the government, and they asked us to do some modelling to see what the potential impact of the key measures included in the action plan might be. So we did that around in 2021. So the objectives of the work was to estimate the health impacts, and those were the effect of these policies on smoking prevalence, on mortality, on health-adjusted life years, including potential differences between Maori and non-Maori people. They were also interested in looking at cost impacts, and initially we did the modelling that we produced was looking at health expenditure and income productivity, but then, as I'll talk about later, we expanded that to other macroeconomic estimates, and we were focusing on the 5 tobacco endgame strategies. 4 of them were presented this morning by Jeanette and Richard, and then the last one is a combined policy package which includes the potential effect of all these policies. So I won't talk about the methodology of our modelling. It's available in the papers for those who are interested. So very briefly, we combined 2 models. We built this tobacco and vaping life history Markov model, and then we combined it with a proportional multi-state life table model, which initially was developed by colleagues at Otago, and we built on what they did and expanded the capability of the model. And there are some references here for those who are interested. So how did we specify the potential effect of the policies? So 5 policies were included in the model. So 4 policies are part of the Smoke-Free Action Plan. The main one is denicotinization, and this column here shows the effect, and in red it shows how this was included or parameterized in the model. So for DNIC, our effect is captured as a 90% reduction in initiation by 5 years after the introduction. And then on top of that, there was an 85% reduction in prevalence by 5 years after implementation. And that was based on an expert knowledge elicitation and a bunch of RCTs, including one that was conducted by Natalie Walker in New Zealand. Second intervention was DNIC plus an enhanced media campaign. So what we did there, we used estimates from an existing model, again from Otago, where we doubled the effect of a routine media or quitline campaign and added it to the denicotization. Retail outlet, very little evidence about what reducing retail would do to smoking prevalence. So again, we used existing modelling that was done in New Zealand by our colleagues at Otago, estimates from Richard's work, and we came up with this effect here, 19.2% reduction in initiation from the introduction of the policy onwards. And then in year one, there was this 19.2% reduction was actually a split between people quitting, and half the people quitting and half switching to vaping. Smoke-free generation, that's kind of data that we got from the Ministry of Health, and that was modelled as a 90% reduction in initiation by 10 years after implementation. And then the combination of all of these. Again, the combination was a bit tricky, not tricky, but it's kind of a complex calculation, and it's available in the paper. I won't spend much time on this. And this is what we got. We first estimated the business as usual, and these are our projections of the business as usual, and we did that for Maori females, Maori males, non-Maori females, non-Maori males. And this is, according to our model, what would happen if no action was taken. So this is largely based on a linear trend that we calculated based on historical data from the New Zealand Health Survey. So I guess this is a finding in itself and a tricky exercise in itself, because there is a lot of uncertainty about what smoking prevalence or smoking behaviour will be in the future. But we're fairly confident about this, because smoking prevalence, as it was discussed this morning, has been pretty stable. There's decline that's been happening for a couple of decades now. And this is the main finding. So this is the effect of the individual policies on, or the projected effect of the individual policies on smoking prevalence. And you have as Richard mentioned this morning, we calculated the effect of each one of the four policies proposed in the Smoke-Free Action Plan, and then the combined effect. And as you can see, this is denicotization, this is denic plus media, retail reduction, and the smoke-free generation, and then the combined package. And yeah, we project a massive decline in prevalence from the introduction of the policy, and that steep decline happens for every population group. So this is Maori females, black line is Maori males, the yellow is the NZ population, the blue line is non-Maori males, and the teal line is non-Maori females. The solid lines are the BAU again, the dotted lines represent the effect, the projected effect of the policy. So if we look at just the combined interventions, steep decline from the policy, consistent with what we specified in the model, and under the combined policy scenario, we can see who reaches the 5% target of the Smoke-Free Action Plan. So for the general New Zealand population, that target is reached within 2 years, 3 years after the introduction of, 2 years after the introduction of the policy, and that is true also for non-Maori population. For Maori population, it occurs at around 2026, 2027. So these are our projections of the effect of the individual policies. And this is just a table illustrating what I just discussed and providing the uncertainty intervals associated with those estimates. And we can see that the initial Smoke-Free Action Plan target was 5% by 2025. Under the combined intervention scenario, only non-Maori females and non-Maori male reached that target. by 2030, all population groups, Maori and non-Maori, hit the target and go significantly below that 5% target. Now, what is the health effect of the intervention? So this is the health gains associated with the combined package, and it's discounted at 3%. And we can see that over the lifetime of the New Zealand population, denicotization, that all the interventions that have denicotization result in massive health gains. And I'll put these numbers here, over 500,000 health-adjusted life years, in perspective a bit later on a different slide by comparing them to the other different public health programs. So the combined intervention here, we can see that most of the health gain occurs around maybe 20 years or so after the introduction. Now, this slide here is showing, again, that how the health policy is distributed between Maori and non-Maori people. So who benefits the most from these, from the health gains? And what we can see here, if we just focus on the combined intervention, what this means is Maori females gain 4.7 times more Harleys compared to non-Maori females. So it's a very strong pro-equity measure, this combined package, but it's true for all of the measures proposed in the Smoke-Free Action Plan. So this is for health-adjusted life years, and an even more, dramatic representation of that pro-equity effect is what we projected in terms of effect on all-cause mortality for, this is limited to people aged 45 plus. So this is showing the all-cause mortality gap and how it's reduced or how it's projected to decrease between Maori and non-Maori. So the blue line here represents the reduction in all-cause mortality in the all-cause mortality gap between Maori females and non-Maori females, around 10%. Sorry, this is for males. And for females, that reduction in all-cause mortality would be around 24%. It's a huge reduction for a single piece of policy that's targeting a fairly limited number of people, i.e. the smokers. So a very strong pro-equity effect here as well. And so how do these estimates compare to other public health programs in New Zealand? We can start by looking at something that we kind of household public health program, which is colorectal cancer screening. It's very cost-effective, even cost-saving. This is what it's been estimated to produce in terms of health-adjusted life years in New Zealand, around 100,000. And we can compare that to the combined Endgame policy package, which in our modelling is projected to produce up to 600,000 Harleys. The only thing that's kind of produces more Harleys or health gains than this is something that doesn't exist, and it's a potential sugar tax. So this sugar tax would be applied to the whole population because everybody eats. Here, the combined Endgame policy intervention applies to, again, a small number of people, the smokers, and yet it generates massive health gains. So this is the paper that we published, and all the technical stuff is in there. I think there's an appendix of 70 pages or something, so people can have fun looking at that. Now, the other thing when we talk about Endgame and that massive drop in prevalence, that something that comes up very often is the cost to government and how that's going to impact excise tax revenue, and we heard the health minister this morning saying that there was an increase in excise tax over 3 years by 5%. I think I read somewhere, or I heard an interview of another minister saying we're generating revenue, it's great. Well, it's true, in Australia at least. We found this in The Age from last year. This is potential sources for where a government can raise money. One of them is tobacco tax. So in Australia, the tobacco excise generates around $12, $13 billion a year for government. So it's not insignificant. So what we try to do here is to calculate the economic effect of the smoke-free action plan in New Zealand. So this is text from the paper, and I think Coral wrote this. Despite the unprecedented potential for commercial tobacco Endgame to increase population health, phasing out commercial tobacco sales often raises concerns about economic impact on government. So we try to quantify the potential economic effect of what's being implemented in New Zealand. As I said at the beginning, in the report we provided to the Health Ministry, we focused on health system expenditure and population income, but then we went back, did some more work, and we came up with these outputs. So we calculated the effect of the combined policy package on population income after tax, GST revenue, income tax revenue, tobacco excise revenue, health system expenditure, of course, GST revenue just from tobacco sales, population expenditure on tobacco, superannuation expenditure, so this is from government, and we also calculated the net government position. The delta here means that all of this is the difference between business as usual and our intervention, which again here is the whole policy package. And we apply two different perspectives. So the first one is the government perspective, and this is showing our projections in terms of the different economic outputs or indicators that I discussed just in the previous slide. And what we can see here, there's a bunch of things that are, generate revenue. For example, superannuation expenditure, the yellow line will go up a bit to around 100 million. So this is per year. It'll peak, it's projected to peak, I think, around 2050. So government will pay more because people live longer. Health system savings, well, that goes up as well. There's less morbidity and mortality thanks to the policy in place. Income tax revenue will also increase because people live longer and therefore, or work more and therefore pay more income tax. GST revenue will slightly increase. The most important bit here, obviously, is the effect on the tobacco excise revenue, which, as you would expect, drops massively here. And then the black line is the net position for government once we've taken into account the gains and losses associated with with this policy. And what's driving this is obviously the tobacco excise revenue, which decreases a lot. So one thing to keep in mind here, so there is a decrease and the net government position is negative, but and the decrease is mainly driven, again, by this tobacco excise revenue. But the tobacco excise revenue is, even under business as usual, is projected to reduce, right? Because it follows the trend of prevalence and the sales, the amount of cigarettes being sold. So what this shows basically is that the policy that is introduced, what it does simply is just accelerate that phenomenon. And it accelerates it quite significantly at the beginning. And then it goes back here, it goes up, simply because under BAU, under business as usual, well, the estimate from tobacco tax is also smaller. That's why the loss is smaller. Now, this is the government perspective. What about citizens? So we calculated this. And it's the opposite that happens that is projected in our model. So through less lines here, we can start with the green line, population income after tax. Well, there is more income in the population because people live longer and therefore they work longer and earn more money. The dotted blue line is savings from cessation, and that increased significantly. And then the population income is the sum of the two, and it's pretty much the opposite of this. This slide here. So that money that's lost, a lot of it goes back into people's pockets. This table here is simply showing the cumulative estimates. So this is in US dollars by 2050, if we look at by 2050. So there'll be savings in the health system expenditure. The government will pay more superannuation. There'll be gains in tax revenue, GST, but then losses in terms of tobacco excise revenue, and as I said, a negative net position. For the citizens, the population income after tax plus saving, we estimated that by 2050 at $31 billion. So in summary, the package, including those policies, if implemented in 2023, is forecast to achieve the 5% smoking prevalence by 2025. Obviously, the modelling was conducted a couple of years now. DNIC is the main driver of all of this. As Richard said this morning, this is probably not probably, this is, in our modelling at least, it's the main policy. The combined package is estimated to reduce Maori non-Maori gap in all-cause mortality, and that's, I think, quite an impressive finding, by up to 23% for Maori females compared to non-Maori females. The Endgame package is projected to generate considerable growth in income for the ANZ population, around $30 billion. Government perspective, the government ends up with a negative net financial position by 2050, estimated at $11.5 billion. Now, we could spend a couple of hours talking about this, I think, but we don't have time. So reflection on uncertainty, there's a lot of uncertainty behind all of this. I can jump just straight to this one. This is the main thing. Cessation due to denicotization, clearly the major source of uncertainty for combined policy package. Richard this morning mentioned around 30 RCTs for very low nicotine cigarettes. We're actually preparing a systematic review to look at these RCTs and work out the estimate. But then there's also the logic behind cessation and reducing the addictive component of cigarettes and what that might do. There's the issue of relative harm of vaping, which we capture in this model. I won't talk about this too much. And there's model structure uncertainty, and then the fact that the New Zealand data of prevalence of both vaping and smoking has changed quite a bit since we conducted the model. I'd like to acknowledge my co-authors and colleagues. Some of them I think are online, and the funding we received from the CRE and the New Zealand Ministry of Health. Thank you.
Do we have any questions in the room for Driss?
Thanks, Driss. That was very interesting. I wanted to ask you, the second graph you showed us with the economic impacts, the black line showing the government's net position is increasing over time. Do you think that if the graph went more to the right, those lines might get closer?
It takes a while. We did it to 20 2021, 100. It takes a while. But I guess it is what it is. Prevention, I think we were talking about this with you or somebody else, but it has an impact. One limitation of this is that we do not capture all of the benefits of this. We have few economic indicators, but there are benefits, including economic benefits, that are very, very hard to calculate. And certainly our model is not capturing all of those. So we address that in the discussion a bit.
Thank you.
Thanks, Driss. What impact on this graph would it have if there was a tax on vaping and alternative nicotine products in terms of bringing that up closer to zero? And what proportion of cessation versus vaping do you have in your model going forward at the behavioural level?
Yeah, so one thing that's missing from here is an alternative where, I guess that's your first question, where this excise tax was moved from tobacco to vaping products.
Yep.
We didn't model that, but obviously it will have an impact, and we can imagine a scenario where all this revenue that's foregone from tobacco sales can be recaptured in vaping. So that's an interesting thing that we can look at. In terms of how you ask a tricky question, it's not tricky, it's just in terms of how people move from CS, current smoker, to vaping, former smoker, current vapor. So that took us a while to parameterize this. We're using data from the UK, where they have estimates of people switching from current smokers to current vapors. I don't have the numbers in my head, and it's actually a massive Excel table. We spent a lot of time parameterizing this, but I can follow up with you, and potentially maybe you can help us determine the thickness of this arrow here.
I think question down front.
Thank you. Thanks very much, Driss. I was very interested in the second present. I've seen the first one a few times. The second one was new to me. I remember, I think, when this sort of came around about that you were doing this analysis, and I was a little bit worried, I must admit, because of the thing about superannuation costs, and these sorts of things can be twisted in various ways, I think. So I was quite pleased, if you like, with what came out of it. And just a couple of thoughts. One was that some people may look at this and say, look, this is a huge cost because government's going to lose all this revenue. And I'm just struck by the fact of the difference in the figures, 31 billion versus 11 billion. So my interpretation of that is that overall this is a net economic benefit to society, which is so government's losing out a bit, but the people who quit are gaining a huge amount in terms of productivity and earnings and so on. So I'm just thinking in terms of framing the results, it's really important to get that across. I mean, the other reason why I struggle a little bit with economic things sometimes is just I don't care so much about this as I do about lung cancer and COPD and emphysema and all the rest of it. So, but having said that, this seems to me to be a good news story, even notwithstanding the loss of government revenue. This is a net societal economic benefit, and it's a particular benefit for people who smoke in economic terms as well as health terms, of course. And so I think the framing of that is really important in how it's presented.
I absolutely agree, and I mean it's a good news story, and I think it's kind of a truthful story, because that's if anything, our estimates of the economic benefits are hugely underestimated. Again, because we're not able to capture a lot of the indicators, just hard economic indicators that government operate on. I don't know, payroll tax, for example, we didn't include that. Companies will be paying payroll tax because people will be alive and able to work for them. But economics it's a very funny science where you try to put metrics against every single thing, but there's stuff that you can't capture. You can't put a dollar value against someone who doesn't have lung cancer or emphysema. I mean, you try, but it's not very, very precise. Our modelling completely fails to do that. So there is a societal benefit, a huge societal benefit, and we try to address in the discussion that limitation in particular. There are untangible benefits that we cannot capture with this kind of modelling.
Was there any other questions? I think also that, I guess a comment would be that from me is that the next stage would be looking at who is benefiting, because this could be considered as an equivalent of also providing a transfer to low-income households, because often it's low-income households that are spending on cigarettes and so on. So they've got a lot to gain economically and so on. Yeah. So looking at the differences between different population groups and how they benefit, and that can maybe help with selling the policy economically in terms of, well, maybe we should be taxing people with more higher incomes than people with lower incomes. So trying to get a fairer tax system than relying on tobacco tax, which inequitably targets often people on lower incomes. And also I think just the percentage of government revenue overall, this isn't going to bankrupt the government.
No, I think that in New Zealand, and Nick Wilson raised that the floods that happened over 2 days cost, I don't know how many times this tiny amount of $11 billion by 2050. But just to your point, Coral, that's exactly what we're working on with the Australian model. We're trying to get those estimates for particular groups in the population. So I think that's very important to have that. So.
Okay. So let's thank Driss for a great talk.